Alright, hello, my name is Chandler.
I'm Josh.
I'm Jonathan.
I'm Chelsea.
And today we're going to talk about MS. MS specifically affects the central nervous system, the oligodendrocytes. What the central nervous system does is that it sends the information between the spinal cord and the brain. And what the oligodendrocytes do are just more specific to the central nervous system, whereas the Schwann cells that you might get confused with is from the peripheral nervous system. Reich et al. Came out with a couple of information that it is the most prevalent chronic inflammatory central nervous system disease. 3 out of the 4 people it affects is women. It affects both the gray matter and the white matter. It is an immune reaction that affects the oligodendrocytes, which is demyelination is what you can really call it. And it costs about $10 billion a year for the United States. Moving over towards the immune response that happens to the oligodendrocytes, the immune response will direct CD4, CD8, and antibodies to those oligodendrocytes and start to demyelinate them. Now, why that's important is myelination, the bigger the coil, the fatter the coil, the faster the conduction velocity is. When you start to degrade those, the conduction velocity can't get from notoron VA to notoron VA, and so you're left with information that can't continue on.
And as far as diagnosis, MS is most easily diagnosed by an MRI. And this is because an MRI can target the big picture of the brain. MS, according to Reich et al., is a disseminated plaque-like sclerosis, meaning it can appear throughout the central nervous system, targeting specific areas such as the optic nerve, the spinal cord, the brainstem, and periventricular white matter. Now, these areas appear as inflammation, large focal areas of demyelination within the white matter, and even areas of glial reaction. In early development of multiple sclerosis, there's an evident change in the blood-brain barrier, which makes it easier to detect the presence of multiple sclerosis in the patient. Another way of possibly diagnosing it was looking at a possible blood immune marker in the body. However, multiple sclerosis is very complicated. It affects many different areas in the central nervous system and produces many different markers. So to find a specific marker for all of multiple sclerosis would most likely be impossible. So we normally stay with just the focal areas of white matter that we see inside an MRI, and these are examples. You can see areas of demyelination within the optic nerve, areas of demyelination within the white matter, and this is what they generally look for in a big picture to identify the presence of multiple sclerosis. And clinical manifestations stem from this demyelination. Demyelination of an axon, as Chandler stated, eventually leads to a decrease in the potentials of saltatory conduction. The potential of the current to pass from notoron VA to notoron VA is largely decreased until a point where it's completely demyelinated and it can't pass that information at all. So when it comes down to transmittance across the synaptic cleft, those neurotransmitters don't receive the action potential necessary to cross the synaptic cleft, and the receptors never get the neurotransmitters to pass the signal. This eventually results in a clinical disability, and this is most obviously seen in areas of demyelination such as the spinal cord, which results in a loss of being able to walk. And there's also a loss of retinal ganglion cells if it is targeted by the optic nerve. These are just a few examples of multiple sclerosis at an advanced level, but it ultimately results in a loss of function in that area.
Alright, so there are no curative treatments for multiple sclerosis, but there are many drugs that have become available. Evidence suggests that they are most effective in the early stages of MS. The most common medications that modify the course of multiple sclerosis include interferon beta, glatiramer acetate, dimethylfumarate, and teriflunomide. According to Reich et al., all of these drugs are approved for relapsing remitting multiple sclerosis and reduce the likelihood of development of new white matter lesions, clinical relapse, and stepwise accumulation of disability. Interferon beta has anti-inflammatory effects and is to be administered by injection once daily to maintain its effectiveness. Glatiramer acetate is a major non-interferon agent and is to be injected once daily. Dimethylfumarate is an immunomodulatory agent with anti-inflammatory properties and is to be taken by capsule twice daily. Teriflunomide is an immunomodulatory agent that is to be taken by tablet once daily. This image depicts major cell types within white matter and multiple sclerosis lesions, along with several current therapeutic targets within the central nervous system.
All right. So in current research on MS, researchers Corinne, Kim, and their colleagues used a mouse model to determine the effects of estrogen receptor beta ligand therapy on mediating remyelination of areas damaged by diseases like MS. So what they ended up doing was inducing encephalomyelitis in mice to mimic the effects of MS. After this, they gave them all estrogen receptor ligands, estrogen receptor beta ligands, and assessed the mice at the peak of their conditions. The mice showed an increase in chemokine ligand 1 levels in both the periphery and in the brain that correlated with increases in axon remyelination despite the extensive immune cell accumulation in the central nervous system. So, how does remyelination work? Well, the mechanism for this process is through the lignodendrocyte's interleukin-8 receptor beta, which binds to the chemokine ligand 1. This causes the lignodendrocyte progenitor recruitment and promotes remyelination. Two findings of great importance for this lie in the reduction of type 2 interferons and the remyelination mechanism triggered by the chemokine ligand 1. With lower interferon type 2 levels, there's less apoptosis in cells, and remyelination promotes growth in the damaged areas. This research shows that there are potential neuroprotective properties associated with estrogen receptor beta and can improve future therapies for MS.
These are our references for the entire PowerPoint and the sources that we used. Reich et al. Was used for all the images, and thank you for watching.